provide patients with education, support, and as well as navigation to other services, specifically fertility services as well. And as well, we do have a large number of online resources. So this diagram really shows many of the unique needs of adolescents and young adults with cancer. So as you can see, fertility is definitely bolded within this diagram, but younger adults with cancer have many other needs, and although they may not specifically be only for this population, we do recognize that these areas of need are different within the population. So that's from sexual health, it could be peer and coping type supports, nutrition, palliative care, exercise, and some of those future life goals. So really my objective today is, and really our objective with our adolescent and young adult program is really to ensure that every patient has an understanding of the risk that cancer treatment may impose on their fertility. And one of our most important take-home messages is that every younger adult with cancer really deserves that opportunity to access information regarding fertility preservation. But whether or not someone actually decides to undergo that process is definitely optional. So that's not necessarily something that they need to do, but we would like you to have the choice to be able to do it. The second take-home message is that really assessing the risk of infertility is very difficult. So I won't be able to actually tell you exactly what your risk will be, as it depends on many different things. So there are differences between men and women, which I will explain today. Specifically for young women, as the age of exposure will have more of an impact on them. Also, if there were concerns with fertility before treatment, and also what's most important is the type of exposure. So the type of chemotherapy, the radiation therapy, the surgery, etc., that does take place. So this diagram is very basic, and what I essentially just wanted to show is that within the testes, that is where sperm is produced, and this is where the sperm can actually be affected, and sperm production can be affected, which can impact a male's future fertility. So estimating the risk for males. So again, as I had mentioned in one of the previous slides, pre-treatment fertility potential is really important to factor in. So if that individual had issues with their fertility before or may be susceptible to those issues, that could impact their fertility. And as well, exposure. So I will mention some of the different types of chemotherapies that someone with lymphoma may receive that may impact their fertility. So really what this diagram, what was important for me to emphasize here is that fertility conversations and the opportunity to discuss something like preserving your fertility as a male should for sure be discussed before you actually start your cancer treatment. So that's the first opportunity that you would have as an individual to decide on whether or not you would like to do something like sperm banking, which I will explain in the next slide. So fertility risks for men. So what is important to understand is that chemotherapy can directly kill sperm. Now, what's also important to understand is that some chemotherapies are more at risk for impacting that sperm longer term and the ability for someone to actually produce new sperm after cancer treatment. So for example, one of the most common treatment regimens for non-Hodgkin's lymphoma is called R-CHOP chemotherapy. And there is a chemotherapy that we call an alkylating agent, cyclophosphamide that is in that regimen that can actually have a longer term effect on fertility if given in larger doses. Also, radiation therapy, if it is given directly within the testicular region or the pelvic region, that can also potentially impact someone's ability to produce new sperm in the future. No matter what, whether it's a chemotherapy that is not an alkylating agent, which is a higher risk chemotherapy like cyclophosphamide, or a lower risk chemotherapy, it is really best to try and preserve your fertility before cancer treatment takes place. So this diagram really shows here what can happen when a young man is exposed to chemotherapy. So once you do receive your chemotherapy, usually within the first 3 months, you won't actually be producing any new sperm until really after the end of chemotherapy, when we can decide what will happen from there. So either you will have recovery of your sperm count over time, or have prolonged azoospermia, which essentially means that you won't actually have recovery of your sperm count. And of course, I can't emphasize enough that this will really depend on your treatment as well as some of your individual risk factors that you may have. So again, the opportunity, if you have the opportunity to sperm bank before cancer treatment, it really acts as an insurance policy in case there is a chance that your sperm count does not come back after you're done your chemotherapy treatment. So sperm banking is really the most evidence-based option for young men to really preserve their fertility. So it's been successfully done since the early 1950s. And we always say, as I was mentioning in the previous slide, that it really acts as an insurance policy. So if there is even the smallest risk that your fertility would not return after cancer treatment, then you would have frozen sperm that you could use to have a baby. For males, it's a very quick process, so usually a referral can be facilitated onto a fertility clinic for you to produce a sperm sample, oftentimes even within 24 hours that this can be done. The cost of this is approximately $300 up front, and then there is a storage fee as well of about $200. So I will speak to you at the end of the presentation about some of the reimbursement programs that are available if this is a barrier for you. So some of the young men that I see that did not have the opportunity to sperm bank before cancer treatment often ask, now what can I do following my treatment? So what can be done is that about 6 months after you're done your cancer treatment, you can have what we call a semen analysis. So essentially, like what you would have done for sperm banking is that you would produce a semen sample and it can be analyzed to see if you are starting to produce new sperm. And this can be performed on a yearly basis to see if that sperm count is coming back over time. So it's important to note that even if you don't have a lot of sperm or any sperm within that first sample after about 6 months following treatment, you still have a very high chance of actually recovering your sperm count within the first 5 years following treatment. But some of the urologists that I work with say that your sperm count could actually even return up to 15 years following treatment. For individuals that have received high-risk chemotherapy, so maybe a lot of a chemotherapy like cyclophosphamide, and if their sperm count is not coming back, then there are urologists that actually specialize in fertility that might even be able to extract some sperm directly from your testicle if needed. Sorry about this. So basically what this diagram shows here is that if you don't have the opportunity to sperm bank before chemotherapy, maybe you're too sick or it was just too difficult for you to actually do that process, then again, after chemotherapy, as I was saying, about 6 months following, you can start having a semen analysis done. And that will let us know if your sperm count is recovering from your cancer treatment or if you may need to go on to see a urologist to see if there's any other way that they might be able to extract some sperm for a baby. So now we'll move on and talk a little bit about female fertility. So within the ovaries, that is where you do store eggs. So usually women, we have about 2 million eggs from the time of birth. The, the difference with men and women is that for men, fertility is not dependent on age, whereas for women it is. So although we have 2 million eggs initially, we lose those eggs throughout our life until we enter into menopause. So our ovaries do age over time. And of course, depending on treatment, this can actually impact your ovaries to actually cause them to age faster. So this diagram really shows what an ovary would look like before a woman hits menopause and then what an ovary would look like after menopause. So of course, depending on the treatment that you receive, some of the treatments can cause you to have an ovary with very few eggs left following your treatment. So again, what this diagram shows here is that what's ideal is that when a young woman actually receives a cancer diagnosis, it may receive something like chemotherapy or radiation therapy or surgery that would impact their fertility, is that you would have access to a conversation around preserving eggs before your cancer treatment. What happens to young women is that once they receive chemotherapy, they can actually lose their menses or their periods within 3 months. Some women that I actually follow never actually fully lose their period, but it can happen, and it does not necessarily mean that you won't have future fertility. So after chemotherapy ends, there are essentially two different things that can happen. So if you receive very strong chemotherapy, so as we were saying with the males as well, alkylating type chemotherapies, so cyclophosphamide, with both men and women, something like a stem cell transplant where they receive a lot of chemotherapy may actually cause permanent ovarian failure. So essentially, you would go into menopause directly from your cancer treatment. What more commonly can happen is that some women can enter into what we call premature ovarian failure. So they may not actually directly go into menopause from their treatment, but would be at risk for going into menopause earlier than, let's say, their friend who has not gone through cancer treatment, so maybe within their 30s. So the evidence-based options to preserve fertility in young women are these two that I have listed. So embryo preservation and egg preservation. So embryo preservation has a very high chance of successful pregnancy, so it's 40 to 50% chance. And essentially what this is that a woman's eggs are retrieved through a process that I will explain, and then essentially are combined with their partner's sperm to create an embryo. And then these are stored for future use. Women who are not partnered can also freeze their eggs alone, so they have the option of doing that. And there's about a 7% chance of successful pregnancy with each egg. Now, what's important to know that if a woman has the opportunity to preserve their fertility before cancer treatment, this procedure is actually covered by OHIP, which can actually cost anywhere from $5,000 to $7,000. So this is actually very new, and it just started to be covered by our Ontario insurance in December of last year. Now, there still are costs for hormone medications, and I'll explain their use in the next couple of slides. But these can cost between $2,000 to $5,000, which are expensive. For many of the women that I have seen that do have some private insurance, um, whether it's through their job or some drug benefits, they actually do cover a large majority of these costs. So what happens in both egg preservation and embryo preservation is that it can take anywhere between about probably 2 weeks to 2.5 weeks to actually go through the entire process. So factoring that in for young women that have to undergo their cancer treatment quickly, this is quite a long period of time. So what it involves is about 10 days of hormone injections that a woman will receive. And essentially that's to help her produce eggs that can be retrieved. The woman from there would have the eggs removed after that under some light sedation. It's not a long procedure, probably, I believe, roughly around an hour or so, and they are extracted through a transvaginal ultrasound procedure. So those eggs are removed and then either combined with sperm or frozen alone for the future to use. So because the process of fertility preservation is quite a bit longer for women compared to men, a lot of times they do not actually have the time to go through this process before, depending on how sick they are from their cancer. So what's important is to discuss the options that are available after treatment as well. So what we do in our program is that for those women that did not have the opportunity to preserve their fertility, they still have the option of meeting with a fertility specialist about 8 to 12 months following their cancer treatment. At that point, the fertility clinics feel that a woman's ovaries will have started to recover from exposure to chemotherapy. What's involved in ovarian function assessment is that an intravaginal ultrasound will be performed to take a look at the ovaries, and then a blood test is also done. And essentially what that does is it looks at the number or gives the fertility specialist an idea of how many eggs are left in the ovaries that can be used in the future. So if the fertility specialist feels that a woman is at risk for going into premature menopause, so into menopause at an earlier age, they may discuss with you the opportunity of actually freezing eggs or embryos at that point in time if you're not ready to start to have a family. And of course, what's really important when you do have that discussion with the fertility team is that you've also had a discussion with your oncology team around when it might be safe for you to start a family. So when your cancer would be at a lower risk of actually coming back. So what is important to emphasize here is that if you decide to freeze eggs after treatment, this process is not covered by OHIP like it was if you had the opportunity to do it before your treatment. So this actually can cost anywhere from $5,000 to $7,000 to do at that point. If you've had a conversation with your oncology team and you're ready to have a family at that point in time, but require something like in vitro fertilization, where they will still need to remove your eggs and fertilize them with your partner's sperm and then reinsert them right away, then that will be covered by OHIP. So some of the relevant resources that I thought might be helpful for you. So there is a summary of both the process for fertility preservation for men and for women in our program brochures that we've created. These fertility brochures were evaluated by both younger adult patients here that were a part of our program and their partners. So we did receive a lot of feedback that way, and hopefully they are straightforward and can be used for either you to look at or for your family members to look at as well. Fertile Future, I will go into that in more detail as well, and that's really reimbursement program that I was talking about to help you with some of the expenses associated with fertility preservation. The Cancer Knowledge Network is also really an important resource as well, because essentially what you can do is on this website you can type in your postal code and it will give you an idea of where fertility clinics are closer to where you live. For healthcare providers, that's also helpful, and that you can make a direct referral through this online network to a fertility clinic for your patients. So the Power of Hope program, there are different types of reimbursements for both men and women. So for women, they can actually help with some of the medication costs that are associated with fertility preservation, and as well as the cost of anything additional to that. And as well for men, they can reimburse of up to $350 for sperm banking. Another important thing about the Power of Hope program is that the individuals that are eligible for this reimbursement must have gone through fertility preservation prior to their cancer therapy. Also for women and men, there are certain limits within household incomes for you to be eligible for these types of reimbursements. So this is just, this screen just really shows the pictures of the fertility brochures that we have created. For those of you on the call that are working at other cancer centers, feel free to print these off our website and distribute them at your center, or you can also contact me directly and we can send you these as well as PDF versions. I also just included this resource. This is a book that was written by Ann Katz, who is a clinical nurse specialist like myself who works in the Winnipeg area. And she has written this book directed towards younger adults with cancer. And it really goes through a lot of the different issues that you face when you do receive a cancer diagnosis at a younger age. And I have recommended it to several of the patients I have followed here, and I have received very good feedback. So that might be a good resource for you as well. I've also included here some of the details on our young adult program. So our email address, our Facebook page, our Twitter page as well. And of course, feel free, you can contact me if you do have any questions about our program or some of the resources that we do offer. And as well, we do have a website, so it's ayprincessmargaret.ca that also has a large variety of resources available. So that is the conclusion of my presentation today. So I think we can definitely open it up to questions now if there are people on the call that have questions for me regarding this information.
Hi everyone, it's Lorna again. Just to remind you, you can use the either the chat function or the question function that should be on your screen, where you can type in a question and we can respond to it that way, or either through the chat mechanism. If you're having problems with either one of those and you have a question, you can also email it directly to me at Lorna, L-O-R-N-A, @lymphoma.ca, and we can look at it that way. Just a couple of things that have come up already for you, Laura.
Okay.
Are there any statistics available on how many women are able to preserve their fertility ahead of time versus those that don't have that option after, before their actual treatment, after their cancer diagnosis?
So I don't have any of those specific statistics for our program as of yet, but that is something that definitely we will look into. Really, what we focus on is that we want everyone to actually receive that information before starting cancer treatment. The fertility clinics, that might be more fertility clinic based as well for women that were actually able to undergo the process versus those that maybe met with the fertility specialist but weren't able to undergo the process.
So, to your knowledge, the ones that usually, if they can't undergo the process, is it because of a timing issue, or sometimes is it because their cancer is advancing and their doctor doesn't want to wait, or is it other issues, or is it just a wide bag?
So I would say primarily it has to do oftentimes with the cancer itself and the timing of if they can delay treatment or if an individual cannot delay treatment. So again, it's very individual based. I mean, some women with lymphoma are able to actually undergo the process because sometimes even before they're able to start treatment, there is a several week wait if they are well enough. But for someone maybe with leukemia, that would be a different story where oftentimes they start their treatment right away. So that's, again, a conversation, a very important conversation to have with your oncologist about whether that's something that would be feasible for you.
Okay. And I just had a comment actually that is from another healthcare professional that sperm banks often want 3 samples with a minimum of days between each sample. So that can also be a problem when treatment needs to start quickly for males as well.
So, I mean, yes, definitely 3 samples is ideal, but a lot of the patients that I do see, 1 sample is actually, they are satisfied with just freezing the 1 sample, and those individuals will still have the opportunity to have children in the future. So, I wouldn't say that that's necessarily a barrier. It would still be great if an individual has the opportunity to just freeze 1 sample of sperm.
So another question, when we're looking at the coverage available to women, why is the focus on those who take action prior to therapy rather than those who don't? So it seems to discriminate against those who can't for whatever reason. So it may not be a case of they didn't want to, it's just it wasn't available, or they may not have been at an age where they decided it was a worthwhile endeavor. Do you have any insight into that? Like even the nonprofit that you mentioned still focuses on those that were trying to preserve therapy prior to treatment.
Right. And I'm not sure if that was just a gap in sort of the decision-making team, that they didn't have that knowledge, because of course, if you think about it, this would also include the pediatric cancer group that may want to preserve their fertility after treatment as well, as they were young at the time of diagnosis. So this is something that we're definitely advocating to the government for and trying to create more awareness around. And I mean, I can't promise anything, but we're hoping within time that this is something that they will reassess and reconsider, because I agree with you, it's very important. And there are many young women, because of the time period it takes to actually undergo egg preservation, that don't have this opportunity.
Thanks. And so for people that weren't able to do it prior, or didn't have the information prior to starting their treatment, what is their best next step? Is it actually finding a referral into a fertility specialist?
So as far as next steps, so I think it's important to have a conversation with someone who is undergoing cancer treatment that about their fertility risks. So talking to your oncologist about what those fertility risks might be as you are undergoing your treatment. But For women, it's important to ask for a referral back to the fertility clinic or to the fertility clinic maybe about 8 months after you've completed your cancer treatment to start having that conversation with them or to actually have an assessment. And for men, a semen analysis can be performed by your oncologist, or your family doctor can even do that as well after treatment.
So where you see, I mean, Princess Margaret Cancer Centre is a big center with a lot of added resources. Are the same kind of resources available in remote communities?
Right. So, that's a very good question. And with our program, it is centered in the downtown Toronto area. So I am actually on an oncofertility task force that we're working with across Canada to help to distribute resources and information to healthcare providers that are working in remote centers. And some of the fertility clinics are trying to work with some of these cancer centers to actually do remote clinics where they can help to advise on individual cases.
Okay, that's helpful. At least we're thinking of the question and trying to work through it, so that's great. I don't have any more questions that have been sent in right now, so I'll just wait a little minute here and see if anything else comes in. Okay. I don't see anything else coming, so thank you very much, Laura, for your time in putting this together and speaking with us. If anyone has remaining questions that they would like answered, you can email them to me directly, again at Lorna, L-O-R-N-A, @lymphoma.ca, and I will make sure we get an answer for you. And hopefully Laura will be able to do that because I just volunteered that. But thank you. So if you could please do that, that would be great, and we'll just make sure you have the information that you need. Again, thank you all for attending. That we will take this presentation and put it onto our website so that we could, oh, you know what, I actually did get a last minute question. I don't know that you actually would know the answer to this, Laura, or not, but what happens to frozen eggs or sperm if the patient actually ends up not making it through their cancer therapy?
That's actually a really good question. There's some agreements that you sign before you actually go sperm banking or before you have your eggs preserved, where you make a decision around what would happen to your frozen sperm or your frozen eggs if you did die from your cancer treatment. So you can, sometimes there's options to either give them to your family, or you would like them discarded, or maybe donated to research. So that is something that's definitely reviewed with you before you donate sperm or eggs.
Okay, thank you. All right. As I was saying, this presentation has been recorded and will be available at a later date on our website if you choose to share it with anybody else that you know, or again, if you have more questions, then please let us know and we will get you answers individually. Thank you, Laura, for your time and commitment to doing this, and we appreciate everybody's energy as well as their dedication to spending some time educating yourself. So thanks you, and we'll speak to you another time. Thanks, bye-bye.